I hereby welcome the judges in Hall A. Dr. Rajiv Saxena, he is Professor, MVJ Medical College. Welcome you, sir. Dr. Uma Singh, Madam, she is Professor, Obstetrics Gynecology in King's College Medical Hospital, Lucknow. And Dr. Rajneesh, he is a Senior Consultant in Bangalore Baptist Hospital.
Good morning, sirs. Good morning to all of you present here. So I'm here to present a paper on obstetric critical care admissions in a tertiary care center, 1 year data of 1 unit, some observations. I'm from Bombay. I'm an assistant professor in St. J.'s Medical College and KM Hospital, Bombay. Basically, dear judges, I'm not presenting in an introduction materials results discussion format. It's just some observations which we have found because it's a prospective observational study. We intend to publish it after 5 years of data. So basically, we have 6 units, out of which I'm presenting only 1 unit data, inter-unit, since we will not be able to analyze in absolute detail of other unit data. So over 1 year, the number of ICU admissions were 58, and the corresponding delivery rate was 1350. So it comes to around 42 per 1,000 births. This rate is comparable to available literature, which ranges between approximately 3% to 10%, and the average ICU stay was 12 days. There were 4 mortalities. Now, the leading causes of mortality in literature are PIH and complications of PPH. Here, what we noticed was the contribution of PPH to the overall morbidity pattern appears to be reducing. In contemporary literature is around 30 to 40%. In our institution, in this over 1 year, it was 12%. Out of which obstetric hysterectomies were 2, medical therapy only were 3, and interventional procedures were 2. So PPH appears to be decreasing. Complications of PIH was surprisingly low. It is a major reduction compared to our own data, where it was almost 20–25%. Here, there was 1 eclampsia with DIC, and severe HELP syndrome were only 2. PPH, contribution of PPH appears to be decreasing. Sepsis. The post-surgical sepsis, there were 4 cases, post-LSCS 3, 1 was a burst abdomen and 1 was post-MTP sepsis. Now, here again, I was looking at the topics of this conference. One thing which was missing was a serious discussion regarding antibiotic policy and drafting of an antibiotic policy, because antibiotic resistance seems to be one of the major contributors to the burden of sepsis, including gynecological patients. Somewhere there is an abuse of antibiotics. Respiratory disorders. ARDS and infective disorders such as swine flu and pneumonia. There were 8 cases of ARDS, which were multifactorial in origin, and 7 cases of swine flu and pneumonia. If you look at literature, in a publication in 2015 and in 2011, both Indian data, there were no cases of infective respiratory disorders. Whereas in an international data, there was a significant increase between 2006 and 2012. Similarly, here also we are seeing that respiratory causes causing raised morbidity appears to have increased majorly. What can be done regarding this? One of these things is that swine flu vaccination is recommended in pregnancy, and it can be one step for prevention of swine flu vaccination in pregnancy. Usually, obstetricians tend to think that, is it safe, is it not safe? It is absolutely recommended. Even the government of India is recommending swine flu vaccination. Liver disorders, it came up to around 17%. Now, the contribution of liver disorders to the ICU load has been predominantly the same. However, the acute viral hepatitis has reduced, and other disorders have taken over. Now, I would like to share some dilemmas which we face when we are interacting with the physicians and super specialty physicians. One very common dilemma which we have faced is whether is it infective hepatitis or it is acute fatty liver of pregnancy. Very commonly, there is raised liver enzymes, there is hyperbilirubinemia, there is sort of IUGR kind of picture, and there is fever. Now, somehow we tend to once there is a major liver disorder, we tend to look to the physician for our diagnosis. Whereas most of the time, if the viral markers come negative, they say they hand it over to us and we do not induce the patient whatever. Here, we have found that the use of the Swansea criteria for diagnosis of AFLP has been very, very useful. Many patients who were viral negative, hepatitis negative, but sort of borderline, who test positive for the Swansea criteria have been induced and later on proven to be AFLP, to have had good outcome after the diagnosis achieved by the same. So here we would like to say, the take-home message I would like to give is that despite involvement of specialty physicians, some diagnosis only we have to reach. Infective disorders, there were 3 cases of dengue and 1 case of malaria. These are typical tropical disorders which the management is very much similar to a non-pregnant. There are some interesting sessions lined up today on complications of heart disease. Basically, the proportional contribution has remained the same. However, the possibility of ischemic heart disease spectrum presenting early in pregnancy has increased. So the take-home point is, don't overlook the possibility of chronic disorders of ischemic heart disease spectrum in pregnant women. In this scenario, we have also conducted a study regarding whether ECG should be included in the usual evaluation of PIH. We were not able to come to any reasonable conclusion, but I would like to suggest this if ECG should be included for a preventive spectrum. Cardiac disorders. We all know that cardiac disorders cause poor morbidity. When added along with PIH, it also causes higher morbidity. This has never been proven. The take-home message I would like to give is that when you are looking at a heart disease, please look at hypertensive disorders, preeclampsia even more seriously. Renal disorders, patients with hemodialysis, nephrotic syndrome, and complication of autoimmune were 6. Hematological disorders were 8. Now, two interesting cases which we saw were, one was a patient with Glanzmann's thrombocythemia and another with afibrinogenemia, where newer modalities like factor recombinant 7A and were used. Basically, the involvement of physician is indispensable. Now, similarly, on the other side, I would like to say that we cannot completely rely on the physician either. For example, a patient with aplastic anemia and IUFD occurred. She gradually progressed from poor Doppler flows to a reversal, and IUFD occurred. However, taking an interest of the maternal interest, we sought to wait and did not induce. Patient went into spontaneous labor because she has such severely low platelet count and coagulation parameters are deranged. Again, yesterday's lecture also told us that fibrinolysis is the most important component in obstetric DIC, and take-home point is, please be patient and do not just induce the patient just because the physician keeps telling, please induce. Most important change to patterns of ICU, malignancy patients. There has been a major spurt of malignancy patients being referred with pregnancy, and recently we had a patient with unknown primary with brain metastasis came with altered sensorium and convulsions. It was not eclampsia. After extensive consultation, she required brain radiotherapy, after which she improved. Fetus has remained alive, LSS is being planned. Most important thing we have to impress upon physicians is that, is amenorrhea due to chemotherapy only? No, it is not. It can be because of other reasons also. So a lot has been spoken about fertility preservation in malignancy patients. We should also think about contraception. Yes, ma'am.
Please conclude.
I've also done one study on knowledge, attitude, and practices regarding contraception among physicians. To summarize, there is a trend in the etiology of critical care admissions in obstetrics. Direct causes appear to be reducing, indirect causes appear to be increasing. Reducing the number of unintended pregnancies among high-risk population is the main preventive strategy for the future. Involvement of the physician, specialist, and the super specialist in preventive contraception is also important.